Fibrin glue to close retinal breaks successfully in complex retinal detachments with oil in situ. Fibrin glue has been used for retinopexy in surgery for simple rhegmatogenous retinal detachments, but there it is used to close breaks to obviate the need for oil or gas tamponade. It has not been reported for complex retinal detachments with silicone oil injection. Our first case 2 years back was PDR with combined traction rhegmatogenous retinal detachment that did not succeed. The retina remained detached with a mid-peripheral superior break. So we took her up for resurgery but could not laser this break even during surgery after additional membrane peeling. So this break was closed by installation of fibrin glue, and we found rapid retinal reattachment in the post-operative period. And this same patient is doing well 2 years after surgery with good vision, intraocular pressure, no inflammation, and the oil has not emulsified, though we have removed the oil recently with an uneventful course. Subsequently, we operated more retinal detachments with this technique. And during membrane peeling, there are some retinal breaks. The bleed is not easily removed from the surface of the retina, so laser cannot be done for these breaks. Fibrin glue is being instilled over these retinal breaks. There are two components of the glue, and each of these is instilled sequentially over each of the breaks that cannot be lasered. And you can see that in the first post-op week, the retina is attached, the glue is resolving by the 3rd week and is gone by the 5th week. Another patient of PDR RD, bleeding during surgery. These breaks cannot be lasered, so these are being closed by installation of the two components of fibrin glue sequentially over each break with a good post-operative result. In this patient, the break is very close to the foveal center. So after membrane peeling, fibrin glue is instilled over the break to avoid laser near the macular center. And on the first post-op day, the glue is closing the break successfully. And by the 6th day, the glue is gone, hole is closed, and retina is attached. Another patient of PDR with complex RD. At the end of surgery, there's a break which cannot be lasered successfully. So the break was closed with fibrin glue. And you can see on the first post-operative day, the glue is seen, the break is closed, and the retina is attached on day 1. And this is the situation after 2 months of surgery. Another patient with a PDR RD. As membrane peeling progresses, there is a retinal break near the macula which cannot be lasered. So we instilled fibrin glue over this break. And you can see post-operatively, retina is attached. And even after a year, there is no oil emulsification, pressure is normal, and the eye is stable. So we have extended it to non-diabetic indications, especially for macular hole retinal detachments where ILM peeling is not possible. For example, this was a patient operated thrice for retinal detachment with macular hole. We instilled glue over the hole, and you can see that the macular hole closed and the retina is attached with good recovery of vision. Another boy with a chronic retinal detachment, macular hole was the only break that had caused the detachment. So at the end of surgery, glue is instilled over the break, over the macular hole. And on the 6th post-op day, the glue is seen covering the hole. By the 10th day, the glue is gone, the hole is closed, and the retina remains attached even a year later. Sometimes the macular hole may remain open, but the retina reattaches, and that's also a good success. For example, this patient operated thrice for macular hole, did not close, on the other hand developed a retinal detachment. So at the end of surgery for retinal detachment, we have instilled glue over the macular hole. And you can see on the first post-operative day, the glue is closing the hole. Retina is already attached on the first post-operative day and continues to remain attached. There is some retinal glue, uh, which resolved rapidly. With regard to technique, check the needle tips for blockage immediately before entering through the sclerotomy, because blockage is common, and attempts to overcome the block close to the retina causes the liquid to come out with high force, which can enlarge the retinal break and lead to excessive injection. Avoid excessive injection, just 1 to 2 drops of each component is adequate. This is difficult because each component is transparent, and even after contact of the two components, the glue remains transparent for some time. So the surgeon does not clearly visualize the injected amount. As far as possible, it's better to use the more viscous sealer protein, which has a blue top, first. This allows overall less spillage. And the two components should be drawn into two different 2 ml syringes, which are easier to maneuver than the 1 ml syringes, which are longer. Fibrin glue migrates subretinally through a macular hole, as we saw in one previous case, and in this case we can see the glue on the scan. And though the glue does resolve in a few days, but if this is a macular hole or close to the macula, any atrophy ensuing from the subretinal glue can cause visual loss. As we noted in some of our patients where there was subretinal glue, the track showed subretinal atrophy after a few days. So glue should not be used for regular closure of macular holes, but only in cases of resistant macular hole RDs. Also, in a peripheral retinal break, excessive injection should be avoided because it goes subretinally and keep the break open. And we had a case where we had to reoperate to attach the retina because of this. To conclude, fibrin glue can be a useful adjunct in the management of complex retinal detachments, especially associated with PDR, when laser for retinal breaks is not possible due to bleed, retinal edema, proximity of the break to macular center, or the macular hole RD itself. The glue is not seen as early as 1 day to 4 weeks after the surgery. There is rapid retinal reattachment, and the need for post-operative position is reduced or even eliminated because now the situation does not require silicone oil tamponade of the breaks. We did not see any long-term adverse effects with silicone oil in situ. There was no inflammation, no IOP rise, and no oil emulsification in the 24 months of follow-up. However, we should avoid routine use for macular holes as it can cause retinal atrophy when it migrates subretinally, affecting the visual outcome, and avoid excessive injection as it can move subretinally and keep even the peripheral breaks open. Thank you very much.